Our next session is how leading payers and providers are revolutionizing data security through advanced data logistics. This session is moderated by Matt Fisher, a partner at Hancock Daniel, where he guides health technology companies and care delivery organizations through corporate and regulatory challenges with particular expertise in HIPAA, privacy security, telemedicine, and cybersecurity. He's also a host of Healthcare du Jour, an award-winning radio show that airs on our own Healthcare Now Radio. For this panel discussion, he's joined by Jeff Eyestone, a healthcare data security pioneer and current Chief Strategy and AI Officer at PNT Data Corp, where he leads strategic initiatives and AI-driven innovations that enable secure HIPAA-compliant healthcare data sharing without retaining PHI and PII. With decades of experience in interoperability and cybersecurity, he is widely recognized as a trusted advisor and frequent speaker on the future of secure data exchange and AI in healthcare. And finally, we welcome to this event, Dr. Mark Boxer, an internationally recognized healthcare technology executive with more than 30 years of experience driving innovation. As a former EVP and Global Chief Information and Digital Officer at Cigna, Dr. Boxer has led large-scale digital health, cybersecurity, analytics, and enterprise transformation initiatives across some of the world's most influential healthcare organizations. Matt, Jeff, Dr. Boxer, welcome, and I'm going to turn this over to you.
Oh, Carol, thank you for the great introduction, and Dr. Boxer and Jeff, it's great to be joined by you today. We'll just get right into the conversation, and I always think it's great to kind of level set and make sure we all are on the same page in terms of where we are. So, as we're thinking about, AI and the use of data and data sharing and security, can both of you kind of share from your perspective, what is that current state of AI, especially in the payer and provider focus, and, how is it impacting data sharing?
Yeah, thanks, Matt. Appreciate it. It's great to be here with you guys and at this event. I'll kick off on that. As Carol said in the intros, I have a long career in healthcare IT and more recently AI, so where I've been working with large payers and providers on all sorts of use cases. I mean, the current state, obviously, it's no longer a futuristic concept. It's here, it's transforming the industry. There are certainly bumps. There are even just in the last couple of years, newer technologies, newer subsets of AI, like generative AI, that are doing a lot. So we look forward on this session to really digging into not just what's happening in AI and healthcare and some of the specific use cases, but where are the challenges and the risks? Obviously, Mark can really get into that with his experience leading one of the largest healthcare organizations in the country. But I'll just start by saying, at PNT Data, we're involved in healthcare data exchange across the payer provider continuum. That's just a subset. Obviously, we're going to touch on clinical use cases, certainly plenty of administrative and financial use cases, claim and remittance processing, prior auths, population health, all sorts of use cases there that are well beyond the science experiment phase, even in those newer generative AI use cases, where in these areas, doing things like helping with claim and auth adjudication, writing up clinical notes and clinical summaries for lots of different uses, pre and post encounter, all the way through to some of those back-end workflows, all the way to things like personalized patient insights, right? We're seeing a lot in terms of data aggregation across health records, in-home devices, and all sorts of things. So a lot we can touch on here. Obviously, there are challenges as well we want to touch on, not just risk management, but in so much as we're involved in data sharing, transaction processing across continuums like payer provider, even ecosystem level data sharing, not just claims and remits, but the chart data that it often takes to adjudicate those kind of things. You see all kinds of different challenges. I mean, in so much as healthcare is a distributed network of disparate systems, we still have interoperability challenges, and AI is doing a lot there, especially some of the newer generative AI solutions around unstructured data, being able to do clinical summaries and that kind of thing, as I mentioned. And then you get into data quality management, data transformation and formatting, and even data governance, data tracking. So that's to say, a lot of data science and AI, the challenges become actually, data access and quality, which is really data engineering. And so we're going to touch on a fair bit of that today. How are we helping address some of what we're seeing in terms of the data engineering challenges, not just the data science ones? And with that, I want to hand it over to Mark and have him dig into some of the risk management.
Well, thanks, Jeff. And Matt, thank you for hosting us today. I'll steal shamelessly from a famous book when I think about AI in healthcare. It's A Tale of Two Cities. So on one side of the equation, we have, tremendous advantages being advanced. When I think about, the capabilities around radiology reads, for example, or the treatment of stroke patients, or the ability to diagnose diseases much more rapidly, or create, personalized care plans using these advanced models, the capabilities are just moving so quickly and are creating so much advantage and improving quality and safety, leaps and bounds. It's just, so much promise on the landscape right now. Yet at the same time, when you think about the risks that come from AI, and I think about especially the intersection points of things like AI and quantum and what it's doing from a cyber perspective, it's just creating, unprecedented risk profiles that need to be thought about and managed. And, I spent time both on the government side as well as on the commercial side. I worked on the health plan side as well as the academic medical center side. And so I've seen every side of the equation in a very fragmented ecosystem. And my job, I always said, was to be constructively paranoid when I think about the cyber issues in terms of healthcare and the ecosystem. And it's just accelerating at a rapid pace. Boards right now, think about AI through the lens of enterprise risk management, but it's not just about accelerating the old issues. It's about creating these new issues, moving things like from phishing to vishing and, being able to steal and then hold onto data and then decrypt it later on. It's just creating much, much different risk profiles. And so my concern as a CIO was always about protecting patient data, but those attack vectors have just accelerated so rapidly. And it's not just about protecting data at rest and in transit. It's about thinking about it across the entire continuum, as Jeff alluded to. And we have such a new security paradigm to think about when we think about AI. But at the end of the day, when we come back to, I chair the board of PNT Data, Jeff drives much of the business there and the strategy overall. You can't steal what you don't have. And our paradigm has been, to not hold data, but simply provide mechanisms to move data. If you go to a bank and don't have any money, you can't steal the money. If you go to an environment and it doesn't have the data, you can't steal the data. So it's about thinking about security through a new lens, but moving away from the traditional models to models that are much more innovative. And we'll talk a lot more about what PNT Data is doing to help our clients.
So actually, that brings up a pretty interesting point where you just said, if you don't have it, it can't be stolen from you. So, I feel like traditionally you hear every party wants to be touching and holding and interacting with the data that's flowing. So what does that infrastructure, that structure look like when all you're doing is facilitating the sharing and then not actually holding onto it yourself?
Yeah, so maybe Jeff, I'll start and I'll talk a little bit about data integrity, if I can. At the end of the day, when we think about how we define data integrity in healthcare, right? It's about certainly accuracy, it's about reliability, it's about completeness, right, and consistency, right from its creation to its eventual use. And that means that we have to think about it through the lens of things like patient safety and compliance and efficiency, but most importantly, about trust. And there have been, and you can count the number of issues over the past year that have happened in terms of the healthcare ecosystem and the breach of trust with patients. And it's so hard to earn that trust that once you lose it, you've got to try to work to get it back. But when we think about data integrity, first and foremost, we're thinking about data governance, right? And data governance includes not only how you're protecting data, but what you're keeping. right? And that gets to things like, data cleansing, gets to things like what permissions you have to giving to users, but also things like your auditing and monitoring of the data. And so when we think about it, we think about it through the lens first and foremost of data governance, and that includes, what you keep and what you hold and how you manage it. We have to think about data governance with a different paradigm today in terms of what AI is bringing into the equation. And when we think about it at PNT, we're thinking about it not only through the lens of traditional protections, but also what actually has to be retained. And our version of the model is that we're not going to retain any data. We're simply going to be a transport for it. And therefore, we don't have to worry about somebody coming in and breaching the environment and taking it, right? Because we don't have it. Jeff, maybe you want to talk a little bit more about our models?
Yeah, and I'll taking it up a higher level for a moment, just AI in general, when you talk about responsible use and trusted AI in healthcare, obviously in clinical applications, it's got to be accurate, complete, unbiased, fair, explainable. There's kind of a technical checklist that a doctor, a clinician is going to want to know that the output of these insights, predictions, risk scores, etc., are to be trusted. Governance more broadly, then you get almost into kind of a nutrition label for AI and analytics applications where model to model, use case to use case, there may be governing bodies saying what is acceptable in terms of, say, accuracy, completeness, that kind of thing. Oftentimes it's 100%, sometimes it isn't. And as Mark said, though, extending out even further in terms of governance, you get into, not just the data science and the model output, but the data sharing. Can I trust that I can get data to a model, to an AI solution, and get the insights back? And that's where, we're bringing in the data engineering piece, but that's a crucial component. Obviously, it's what kills a lot of AI projects. Is not the data science, but the data engineering, right? We can do this in-house, but we now need to extend it out to, say, providers or patients and members. Things start to break down fast. So a lot to do in terms of expanding the definition of data integrity to not just include the AI application itself, but the insights. And that's where the no PHI, no PII, no data ownership, et cetera, becomes important. I mean, this is the intellectual property of a lot of healthcare organizations, AI solution providers, and you've got to manage to that as well in terms of data integrity. Not to mention the tracking of data. How do I see where all of my data is even? A lot to do there.
And it sounds like you're talking about that data flowing to, correct me if I'm wrong, but the AI vendor or other vendors, which sounds like it's kind of a component of your vendor management. Because if you're the contracting organization seeking the service, if you can keep your data with yourself and not worry about it in the hands of others, which I think if you've been kind of following any breach notifications or just general news about where attacks are going, the vendors are a rising target, if not the primary target at this point. So as I said, it sounds like that security strategy then is have a better picture of your vendors and really think through what, if any, data needs to go into their, under their control or with them holding it, and how can you leverage their services without transferring the data over to them?
It's an interesting question, interesting dynamic, and just to sort of put a finer point on what Jeff said before I talk about the vendor perspective, the role of the SMEs in terms of making sure that the models have integrity, but also that the data governance has integrity is absolutely critical. And, it's not about abdicating responsibility. It's about providing an additional layer of responsibility on top of the models, with the SMEs not only verifying the models, but ensuring that the data flows have integrity into and out of the models. There's interesting about bias in terms of the models and thinking through that lens. Well, the SMEs provide a checkpoint certainly in that process, but also the integrity of the data flowing in and flowing out. And that gets to the point that you just brought up around vendors, which is in many ways, we need to think about the healthcare ecosystem, not within the four walls of the organizations that we manage, but as the extended enterprise. And these days, getting a handle in terms of that extended enterprise and making sure that you understand the supply chain is absolutely critical. In terms of managing the risk around cyber and making sure that you're thinking through the risk profiles in the right way. We have an obligation to make sure that we are vetting our vendors in terms of the protocols that they have in place from a cyber perspective. And it's almost like doing a due diligence for an M&A when you're thinking about the extended enterprise. It's making sure that not only does your own environment have the right toolkits in place, the right processes, and so forth, but making sure that your vendors and your partners have those as well, and proactively looking at them, not just as a compliance checklist, but an ongoing process to make sure that as new models are evolving and new capabilities are being brought into the mix, that you're understanding the emerging risk profile that exists there. And Jeff, I don't know if you want to add any commentary to that as well.
Yeah, I think there are a couple of topics that are in the news a lot just in the last couple of weeks that I'll add to this part. Especially, it usually relates to vendors if we're talking about healthcare payers and providers, and one of those is related to generative AI and understanding the underlying models and where is that data going. I mean, business things like putting contracts and pricing in there and then sharing the chat with your own colleagues in your own company. We're seeing in the news things like those shares have become searchable. They've turned it off since at Google, but it does make you wonder, in terms of if your data is your intellectual property and you're putting it into third-party models, what's happening to it? It's just an issue to be aware of and understand enterprise licenses if you need to own the data and the outputs. And then another one tangentially related, but certainly in healthcare very common, is all this talk of agentic solutions, AI agents. We at PNT talk about data access agents and transaction agents because we're leveraging a lot of this technology to build out those kind of data sharing ecosystems. And it's been in the news where agents are also at risk at a component level. So again, if you're combining all of this into, say, a clinical summarization agent, a medical necessity agent, an adjudication agent, trying to shift left rules engines out to providers so they can see what it takes to submit a better claim or a better auth, that kind of thing, and try to reduce friction. It's just another vulnerability point, right? Agents, as a broad term, AI agents, healthcare AI agents, and then even all of those data engineering agents that we could consider to share data all full circle. So a lot to think about there in terms of your vendors. How are they bringing the security and privacy governance, everything we talked about in terms of data integrity to those kind of solutions as well?
Jeff, right, I was going to say, when you talked about agentic AI, the risk profiles increase dramatically when you think about the capabilities that they bring into the mix, and the risks that are introduced with the sophistication of those models.
Yeah, and kind of picking up on what you're both saying there with those, those new models and the sophistication of the models, and Dr. Boxer, you just said, you have to do the kind of that deep diligence dive, and Jeff, you picked up on that point too. It's, what are you looking for, and like what questions do you think should be asked as you're going into that diligence process, especially if you have these emerging technologies where the entity seeking to utilize that tool may not fully understand or appreciate how it operates and might not be aware of all the questions that should be asked to ensure that data integrity is being maintained.
Jeff, do you want to begin?
Well, yeah, sure. I can. I would love to see the CIO's perspective, having hired a lot of vendors myself. but no, it's I mean, in terms of specific questions, I think actually the AI, some of these tools provide, only because I've done this recently, we now have a dynamic in healthcare IT, healthcare AI, and especially data sharing, the need to go through really rigorous InfoSec questionnaire processes, usually with a third party scoring you, right? Good news is once you do one of those by vendor, there are several. you get pretty good at it. But what they do is they really help you expose, where you could improve yourself. We at PNT fortunately have passed with flying colors. That's a quote. With some of the highest scores, that's what we do, is enable secure data exchange. So we were glad to hear that. But what I would recommend, having done this with startups and in other environments, and even as it relates to generative AI, which are some of the more recent ones, is go get a hold of some of that information. Start to figure out, how would you do in those types of really rigorous third-party evaluations. That information's out there. Those kind of organizations can help you. They have a vested interest in getting paid by your clients to get these scores on your infosec, your risks, etc. So it's a worthwhile exercise to dig into some of that. Now, I'd pass it over to my chairman, who's been a CIO and hired lots of vendors. I'm curious here.
Yeah.
Myself.
So, we talk a lot about the technology and the tools and so forth, and the certifications and the validations and the checklists. But if you look at some of the more recent data breaches, some of the more serious ones have happened because of human error, right? And so it's making sure that, when you think about it, it's not a matter of if, it's a matter of when. I mean, I fundamentally believe, unfortunately, that everybody's going to be breached at some point in time. So it's making sure that there's, rigor in terms of the processes, but hiring people that, are making intelligent decisions and segmenting the environment, right? And bounding the exposure. And again, I come back to the fact that, if you don't have it, you can't steal it. So making sure that there is a very, very rigorous process on an ongoing basis to really validate what data needs to be retained, how it's retained, who has access to it, how it's protected, and most importantly, not thinking about just within the four walls, but the extended enterprise that exists. The ecosystem is fragmented, right, and distributed. And therefore, we need to think about the environment and the security protocols as being, unfortunately, fragmented and distributed. So again, I continue to encourage us to think strongly about validate, but also thinking about the human errors that potentially could exist in bounding those environments in ways that minimize the exposure.
No, I think that's a great point. As you said, it's, the technology can work perfectly or be set up, to protect the information as best it can, but you always have to account for the individuals who are using it, because you referenced it already about all the different forms of attacks that are targeting individuals. That is more likely than not going to be the way an attacker gets in and is able to compromise the system.
And one of the more recent ones, Matt, involved vishing, and the ability to create deep fakes, and we have these people that run help desks that potentially can be fooled into providing credentials to someone that they think they're dealing with, when in fact it's not that individual. So again, it's not a matter of if, unfortunately, it's a matter of when, and making sure that, again, we're thinking through the data governance, as Jeff alluded to, and bounding the environments in ways that minimize the exposure.
Yeah, so I think there's been kind of a lot of theoretical and broad-based discussion around how do you maintain data integrity, and how do you go about kind of creating the relationships in the first place. But I always find it very helpful and instructive to get some real use cases and examples out there. So I think both of you have been talking about how you're working in the field and creating these use cases. So would love to hear from both of you, a few different use cases that provide concrete examples of the different processes and methods that you're talking about.
Yeah, sure. I'll dig in there. I've been about 8 years working inside of large payer and provider organizations, even financial services and retail, other industries, across clinical, administrative, financial, research, other use cases for all sorts of AI applications. Mark will focus on some of the more sexy clinical use cases. I'll touch on some payer and provider, administrative and financial ones, and even get into a little bit more of some of the more recent generative AI solutions that have evolved over a couple of years from, in-house science experiments to some things that are actually working. I mean, we try to sell to value, not just implementation and that kind of thing. So, but no, at PNT, we're primarily focused, as I say, on payer provider use cases like claims and prior auth processing, especially where there's a lot of friction, where data quality, data formatting, edits and validation, mixes of structured and unstructured data combine to create, adjudication, reconciliation friction, lots of costs, where Mark will touch on clinical use cases that, can help drive better quality of care, cost of care, things like that. Usually we're talking about things like efficiencies, people time, and processing costs. Although, obviously in these workflows, you get into things like denials management and downstream processes like appeals and grievances, payment integrity. There's tremendous value in what AI is doing in these areas, everything from data intake, dealing with that unstructured data, to, like I said, things like clinical summaries that help with the adjudication process. The more challenging claims and the more challenging auths, the ones that require human review, are often those that come with all that additional data, right? And they require a subject matter expertise to decision them, that adjudication process, not to mention the back and forth, all of the acknowledgments, the status, and eventually the reconciliation. So there are just lots of administrative and financial use cases through these workflows, right? And like I say, downstream with appeals and grievances, payment integrity. If you're, say, a delegated group, an ACO, a Medicare Advantage plan, then you have things like aggregated information, even just analytics around who are my expensive patients, out of compliance providers, out of network referrals. All of that sort of work now is becoming prime target areas, just because these are such high value use cases, right? And like I say, even just the data engineering part, there's a lot of AI across that continuum. So using updated tools to deal with data intake, quality control, and transformation to make it more usable, all that unstructured healthcare data. So let me turn it over to Mark. You talk about some clinical use cases.
Well, thanks, Jeff. I mean, I'm really, really excited about the opportunity set that's coming on the clinical side from these very advanced models. It used to be that I used to like to say that it took about a decade from bench to bed. And what I meant by that was from the time that the evidence gets developed and goes into the journals and gets into the hand of the frontline physicians, it could have taken up to a decade for that to happen. And therefore, the evidence-based guidelines were always lagging behind the actual practice of care at the bedside. And now, with these models in the hands of the physicians, they can have the latest evidence-based there, intelligently helping them advance the ball diagnostically, literally in nanoseconds, which is incredibly exciting. And you think about a couple of the use cases, and I say things like the diagnosis of breast cancer, even simple things like an X-ray read for a fracture or potential fracture, right? The models are so much more advanced and intelligent that can do things that the frontline physicians could never do on their own. But it still takes the frontline physician to be there to guide the care. And I'll talk about the reason for that in a minute. You can't these days open a newspaper or a magazine or read an article online without it talking about welcome Dr. Chatbot. Then the challenge is that patients are using these chatbots to self-diagnose, and in some cases getting it wrong. So the ability to have that, clinical oversight by the physician, augmented by the models that are really moving the evidence base into their hands quite rapidly, creates, a quality and safety dynamic that is unprecedented. Radiology is one case that I continue to cite. It was interesting because recently there was an article written that says about 44% of patients that have diabetes don't even realize it. So the ability to diagnose much more rapidly, create longitudinal views of an individual, deal with things like the social determinants of health in ways that we couldn't do, are just moving very, very rapidly. And I'm very, very excited about the possibilities. But again, it's a double-edged sword. When patients look at that information and use these these chatbots are self-diagnosed. Sometimes they get it right, but many times they're getting it wrong. So making sure there's the right clinical oversight and guidance in place is so important.
And there's a lot to unpack there, and as you said, it's kind of falls across the spectrum of potential use cases. And Jeff, I think maybe I'll turn to a couple that you mentioned first, and maybe let's kind of hone in on that claims adjudication piece that you mentioned, because I imagine that involves or could involve traditionally a fair amount of data exchange, because I think as you were alluding to, you have the initial claim being submitted. You might need to have the medical record review and other information going back and forth. So focusing on that data transfer aspect, how are you seeing a shift in that implementation of the process through the availability of new technology that is minimizing the transfer and hopefully better promoting the maintenance of privacy and security throughout that that necessary process of exchange, but one where there are potentially a lot of hands entering the picture.
Yeah, it's a great question. Happy to double click on this. I mean, it really, anything that adjudicates, there are a couple things I could say. But base level, where's AI making an impact on a claim or a prior auth? There's a line of demarcation, if you will, from those that are relatively simple and EDI works end to end and back again, and those that don't. The ones where you need to show medical necessity or claims that have attachments, that these EDI transactions that require additional information that's almost always unstructured and problematic, challenging, creates a lot of friction. In the case of auths, there are lots of prior auth types. So, you have to get very specific, from prescriptions to radiology, inpatient, outpatient, DME, et cetera, et cetera. They come with different things. And so to start to apply AI solutions to them in these use cases, you want to reduce adjudication friction, get data back. You may even be looking to do things like I mentioned earlier, shift left, put the rules out on the network in hopes of getting more electronic data, higher quality data, data that leads to less friction, populate models better for the sake of adjudication, and then the downstream process. It's like I mentioned appeals and grievances. Let's have fewer denials. That'll make both claims and auth appeals even better. Those kind of use cases all have discrete parts of those workflows that could leverage AI, right? And then you have, of course, reconciliation. How do you put all this together across the workflow even better? All in the name there of efficiencies. But then if I pull back the aperture a bit and look at these workflows, things like a claims history or a prior auth history for a member for the last year or two can be very instructive in other workflows. It can even be feeding patient and member facing applications, care management applications, that kind of thing. A claims history itself is very challenging, even for the kind of organizations that have all of the claims for a member / patient. So those sort of use cases, when you pull back again, can require some good AI. And lastly, then you have, with the advent of generative AI, we heard on the last panel some interesting things about Anthropic and other vendors, ChatGPT from OpenAI. When you have now model context protocols and ways to extend the capabilities out into other databases, that's where this shift left, where can a provider enter, I have a headache patient, needs a brain scan. What are the criteria I need to get the auth? Where do I get the data? All of those tools are going to come fast. That's happening now. But those are areas where it looks like a claim and an auth, but it includes, an ability to dig into EHR data, chart data, prove medical necessity, write up quickly, the kind of summary, fill out a form, submit in the right format, submit against the rules for a specific plan. Those are all discrete. That's why I use the term agentic. You'll see, components like that happening soon that actually work really well. It's just now you have to deal with all security, privacy, data integrity ramifications of that.
So kind of as you're doing all that, like, or trying to take advantage of those benefits, how are you, best integrating that into your existing tools? And it's, Jeff, you're just talking about, it might be interacting with the EMR or, and then, potentially helping with adjudication against plan standards. It's, have you seen a best, or not, maybe not a best way, but kind of a recommended way, or had seen lessons learned of how best to get that integrated into, as I said, the EMR or other existing systems, so that way it enhances the ability to use the solution and take advantage of the output, but then, as you said, at the same time, optimally maintaining or enhancing the privacy and security along with it.
I haven't seen it yet, actually. Unfortunately, I would say it's I mentioned it's on the way. It's going to happen. There are, I'll say they're more than just science experiments. There are big organizations in discrete parts of this, like prescription auths, for example, where you have the vendors at play who are the subject matter experts and the prescription rails doing things to enable this. It isn't yet at the level where it's built in EMRs. It's more of a network play, a combination of payers, vendors, and provider organizations coming together. You'll have interoperability and scalability challenges for providers to use it. You want all your payers in there or all of your various data pipelines. So, prescription auths may be a really important one as an example, but you'll quickly look for how could I do all my auths this way. But the technology is there. It's no longer a technology challenge; it's more an implementation challenge.
Yeah, and I think I would even go further and say, there are examples of delivery systems and there are examples of payers that are cracking the nut on this. And what I would like to say is that, the EMR, the EHRs are necessary but not sufficient. The definition of health is broadened, as we know. And the determinants of health go way beyond those elements that are existing in the EMRs. The social determinants of health include things that are not collected traditionally in the EMR. So the ability to build a data environment, a data infrastructure that aggregates the data together. And I come back to where we started, which is a fragmented ecosystem with many partners and vendors in the mix that require us to think about this more broadly than we ever have before, not only from a cyber perspective, but from a data governance perspective as well. And there are places where it's being aggregated together and being mined very, very effectively, where the models are being applied then much more broadly than just what traditionally would have existed within an EMR, number one. The second thing I would say is that, the models are getting more sophisticated, but it comes back to the basics in many ways. And I'll use an example. There is the ability, and there has been the ability for many years to mine the data in terms of prescribing patterns of doc, to identify those that are prescribing outside of the right protocols and creating, opioid addiction issues, and then be able to intervene and say, hey, we need to change how you think about your prescribing patterns. But we've got to do that in a way that, thinks through the ecosystem and all the data that needs to come together, whether it's the data that exists within the payer space or the PBM space or an EMR within a delivery system and so forth. But there are those that are cracking the code on getting this done today.
Yeah, and I think kind of picking up on the point you just made, Dr. Boxer, about pulling in information from different sources and making sure that you've got everything, all the different data points, and especially because, you don't have a complete picture in any one repository. This maybe goes back to a point that you were making earlier about the potential for AI to be enhancing interoperability. So, how do you see that advancing, and how does that interact with, to some degree, the regulatory push for identifying common data sets or data standards?
I'll give you my take on it. I mentioned interoperability just because, what this technology is letting us do is put a bit more of those data access, data quality, and data transformation capabilities out on the network. So, historically, where tiny little changes in format or the requirements for, say, editing and validating up against a rules engine needed to be handled by third parties and that kind of thing. Now, we can apply agentic AI and other capabilities, for example, to those workflows. I'm talking about transactional workflows, but this would apply to clinical data aggregation, all sorts of different use cases where now you can, build out by use case all of those requirements, everything it takes to get quality control, transform, and then govern, as in data tracking,